Hello and welcome to lectures on cardiac morphology and congenital heart disease. This video is on Conotruncal anomalies part 1, Tetralogy of Fallot, and double outlet right ventricle. So in this video we'll have the following specimen. Tetralogy of Fallot with the paramembranous VSD, Tetralogy of Fallot with the juxta-arterial VSD, Tetralogy of Fallot with pulmonary atresia, absence of ductus with systemic to pulmonary collaterals. Tetralogy of Fallot with pulmonary atresia with the ductus with preferential flow to the left side. Tetralogy of Fallot with aortopulmonary window. Double outlet right ventricle with straddling tricuspid valve. Double outlet right ventricle status post Rastali operation and left ventricular ischemia. Double outlet right ventricle with a subpulmonary ventricular septal defect. And finally, double outlet right ventricle with pulmonary stenosis and Rastali operation. So we have a lot of samples for you. So let's go ahead and get started. So in this video, we will review the anatomy of tetralogy of Fallot and double outlet right ventricle. So if we look at this specimen with tetralogy of Fallot, we can see why the unique shape of the heart that is present in tetralogy of Fallot. So this is the right ventricle, and as you can see, it's hypertrophied, and this hypertrophy causes the left ventricular apex to be lifted up like so, and that gives the unique boot shape of the heart. And if we look at the pulmonary artery, it's also hypoplastic compared to the aorta. It has this unique concave shape, as you can see, compared to the large dilated aorta. So that gives this unique shape of the heart. This is the left ventricle and the small pulmonary artery. If we look at the pulmonary artery, it is very small with small pulmonary artery branches. And if we open the heart, we will realize why is that. We're looking at the right ventricle here, and this here is the tricuspid valve. And if we pay close attention, we see the aorta here arising mainly from the right ventricle, and this is the pulmonary artery separated from the right ventricle by this thick infundibular septum, which causes the stenosis of the pulmonary artery and the outflow tract of the right ventricle. If we follow the flow of the pulmonary artery, we see that the pulmonary valve right here is usually bicuspid, and the whole pulmonary artery is small and hypoplastic. Let's open this pulmonary artery. We can see that the pulmonary artery branches are also small. And in this case, of course, the ductus arteriosus is extremely important to maintain. This is the ductus right here, and it's important to maintain the pulmonary flow, which is reduced due to. So if we look at the left ventricle, we can see that the aorta, which is also arising from the left ventricle, is straddling the ventricular septum. So it has both communication to the right and the left ventricle. And because of the presence of the pulmonary artery stenosis, both pressures in the ventricles are equal due to the large ventricular septal defect that allows this pressure to be equal. And then the aorta receives blood from both the right and the left ventricle, which is typical of tetralogy of Fallot. Okay, so the next specimen is another variation of tetralogy of Fallot. If we look here at the aorta is large, and the pulmonary artery is small and hypoplastic. And if we open the right ventricle, we see and we trace the right ventricular outflow tract right here towards the pulmonary artery. We see that the outlet septum is defective in this case. So the pulmonary artery and the VSD and the aorta are on the same level, and this is the defect communicating both to the aorta and to the pulmonary artery. So the stenosis here in the pulmonary artery is not caused by the hypertrophy of the outlet septum, rather by a valvar annular hypoplasia. And the defect is large enough, as you can see, to communicate both ventricles and cause to have equal pressures on both ventricles. So this is a case of a subarterial or juxta-arterial VSD in tetralogy of Fallot. And the key of survival to this patient is to maintain pulmonary flow, which in this case was done by creating a systemic to pulmonary shunt, which is a Blalock tossing shunt in this case. As you can see, the shunt goes from the aorta into the right pulmonary artery, maintaining the blood flow to both pulmonary artery branches. Let's look at the next specimen to see another example of Blalock tossing shunt and tetralogy of Fallot. So here, if we look at the external surface of the heart, we can see this is the left anterior descending coronary artery, which again demarcates the ventricular septum. Here we have a large hypertrophied right ventricle, and the left ventricle actually is normal in size, not as small as it may seem. And here's the aorta, and here's the pulmonary artery, or where the pulmonary artery was, the stump of it, but it was dissected, and this is the remnant of the stump. To provide the pulmonary flow, there was a Blalock tossing shunt right here, which was connecting the right innominate artery to the right pulmonary artery to maintain blood flow and blood circulation. And this is typical in this case to allow the pulmonary artery branches to grow, since they have low resistance and pressure at this period. And later on, when the patient size is normal and allows a communication between the right ventricle here and the main pulmonary artery and main pulmonary artery branches, and that can be done through a graft. And in some cases, if this is not possible due to the internal arrangement, and can't be converted into a single ventricle. Now, if we open and looked at the internal arrangement, we see here the tricuspid valve, and here's the mitral valve. Here's the left atrium. This is the right atrium right here, and here's the ventricular septal defect between the left ventricle here and the right ventricle there. And if we look through the defect, we see the overriding aorta. Let's say this is the aortic valve right there, and that's typical of tetralogy of Fallot. Now, let's take a look at an extreme form of tetralogy here. As we said, the pulmonary artery can be hypoplastic, but it can also be sometimes completely atretic or severely hypoplastic, as in this case. So if we look here, we see that the pulmonary artery is almost atretic, severely hypoplastic in this area, and also the pulmonary artery branches are very hypoplastic and did not grow. And the reason for that is because there's no patent ductus arteriosus in this place where it usually is to supply the pulmonary artery branches in the fetal life and cause growth of the pulmonary arteries. So due to the absence of this pulmonary of the ductus arteriosus, the pulmonary branches did not grow. So due to the absence of the ductus arteriosus, we expect an alternative source of blood to the lungs and to the pulmonary artery. And to look for that alternative source, we need to flip the heart and look at the back. So once we removed all these labels and structures, we can see the trachea here. Here, can you just hold that, please? Yeah. Okay, so this is the trachea, and just hold it well, please, here. So this is the left-sided aorta and a descending aorta. And if we look here, we see branches coming out from the descending aorta to the left side of the lung and to the right side of the lung. So these are the alternative blood flow which are systemic to the lungs, in addition to the pulmonary flow to the lung. So this is major aortopulmonary collateral arteries, or MAPCAs, or SPCA, systemic pulmonary collateral arteries. Both terms are used to describe this condition. But although these branches can provide pulmonary flow to the lungs, and sometimes adequately, it remains a big challenge for the growth of the child, as these arteries need to be incorporated into normal pulmonary circulation for this child in the future, and that's a major challenge. Okay, let's take a look at this next specimen. No, not this one. This one. Okay, so in this specimen we will see a typical tetralogy of Fallot, however, in the presence of a patent ductus arteriosus. So if we look here at the right ventricle, we can see the ventricular septal defect and the aortic valve here, and the pulmonary artery, pulmonary trunk, and here's the pulmonary valve, which is almost atretic here. And it's a bit out of focus. Let me try to work on the focus. But look at the here closer. Yeah. So this is the patent ductus arteriosus connecting the aortic arch to the pulmonary branches. And this is crucial to the growth of the pulmonary artery branches. So in this case, it's connected to this left pulmonary artery, as you can see. So the left pulmonary artery had normal and good growth. However, it's not the case to the right pulmonary artery, which is coming from here. And you can see there's like a coarctation type lesion there, like a web that is causing obstruction of flow to the right pulmonary artery. So it is crucial to maintain that pulmonary supply by the aorta to provide adequate growth to both pulmonary artery branches. Other than that, if we look back again into the internal structures, it is a typical of tetralogy. So this is the right ventricle, the VSD, the aorta here. And if we look on the left side, again, this is the aorta overriding the septum, communicating with the aortic arch. So here's another specimen. As we said, there are several ways of creating a systemic to pulmonary shunt. This is one specimen of a case. If you look here, you can see that the pulmonary valve is very small, hypoplastic, and the pulmonary circulation was sustained, however, not by a surgical shunt, but by a natural shunt. You look here closely and you see a aortopulmonary window that can be associated with tetralogy of Fallot. So in this case, the AP window provided and sustained the pulmonary circulation naturally and not through a surgical intervention. So a common association of tetralogy of Fallot. Okay, so let's now shift gears and change lesions and look at this specimens right here. This is a case of double outlet right ventricle. So if we open the heart and look at the intrinsic anatomy, we can see here that the aorta, as you can see here, is coming from the right ventricle. This is a spectrum of diseases where the aorta would be rising partially or maybe completely from the right ventricle. If we look here at the external surface of the heart, we see that the aorta is actually rightward and anterior. If you can help me just hold that lobe, yeah. So if we look at this pulmonary artery, it is arising from the right ventricle right here. And the aorta is arising from the left ventricle right here. But the relationship of the aorta to the pulmonary artery is malposed. And that is not unusual, especially when the pulmonary artery is atretic or near atretic, like in this case. So this is the hypoplastic pulmonary artery, and this is the aorta right and anterior. Now, if we look inside the right ventricle, we see that the aorta, which is here, the aortic valve, is separated by from the ventricle from this circumferential thick infundibular septum. So in physiological sense, actually, this is almost like a transposition physiology, because the aorta is coming entirely from the right ventricle. And if we look at the right ventricular side, of course, the pulmonary artery is nearly atretic, so we cannot see the right ventricular outflow tract there. Now, the interesting thing in this case is this tricuspid valve. So look at this leaflet. The septal leaflet of the tricuspid valve is not attached. You don't see attachment to the right ventricular side. This is the septal leaflet. See how it's straddling the ventricular septal defect and having attachments through the defect into the left ventricle. As a matter of fact, to the free wall of the left ventricle right there. So this is a straddling tricuspid valve. So in this case, the valve, the tricuspid valve, is straddling the VSD and filling, in this case, here you can see the inferior part of the left ventricle having inflow from the right atrium through this tricuspid valve, but most of the inflow is actually coming to the right ventricle over here. So that's a straddling tricuspid valve. Now, if we look at the mitral valve, we can see that the mitral valve here is located anteriorly relative to that straddling tricuspid valve, and that will allow the inflow to the left ventricle to be intact. So this is a case of straddling tricuspid valve in the setting of a double outlet right ventricle. Now, some people may call this transposition with an atretic or pulmonary atresia, a transposition with pulmonary atresia. That can also be called. Now, the RPA, if we look here, it is a little bit having an unusual course because it's connected through this Blalock-Tossing shunt that you can see from the right innominate artery to the right pulmonary artery to provide pulmonary flow, which is compromised in this case. Okay, now let's take a look at this next specimen. This is a post-operative specimen, and this is a double outlet right ventricle repair with a Rastali repair. So this is the right ventricle, and that's a conduit. It's a prosthesis, as you can see, interposing between the right ventricle here and the pulmonary artery there. If we open up and look at the internal structures, we can see this patch. Look at this patch here. That is closing the ventricular septal defect, and this is the right ventricular outflow tract that continues with the prosthesis or the conduit, the Rastali conduit. Now, this patch, the aorta is right underneath that patch. If you imagine this patch not present, the aorta was there actually, but then this patch caused not only closure of the VSD, but also baffling of the flow from the left ventricle into the ascending aorta. So it's more like an intracardiac baffle rather than a simple VSD patch closure. And this baffle will allow the continuation of the left ventricular outflow tract to the aorta. Look at the outflow there from the LV to the ascending aorta, unobstructed, which can be very challenging. Now, in this particular patient, the pulmonary artery were hypoplastic, and the first surgery was a BT shunt to allow growth of the pulmonary artery branches, and then the conduit was placed here to after the PA branches have grown sufficiently to the right size. Now, this patient has done well actually initially after the surgery for 10 months, but then he started having left ventricular dysfunction, and this dysfunction, as you can see here, the endocardial fibrosis was thought to be related to coronary artery perfusion compromise, and then post-mortem, where we realized that the left main coronary right here has been compromised with the sutures that were used for this conduit placement. Okay, let's take a look at this next specimen, which is another variant of double outlet right ventricle. Let's put the heart in normal orientation here. Now, this is the right ventricle, this is the left ventricle, and we have two great arteries. This is the aorta. Let's put them in the normal orientation here with my helper holding. Good, thank you. So the pulmonary artery here in my right hand and the aorta in my left hand. If we pull this up so we can open the right ventricle here and see how both great arteries are rising from the right ventricle. Now notice in the subaortic area, this is the infundibular septum or the outlet septum, and the infundibular infundibulum beneath the aorta is complete. It's circular and complete and thick, actually. Whereas a subpulmonary conus is incomplete. There's actually fibrous continuity between the pulmonary valve and the mitral valve. And that's can also be considered a variant of transposition of the great artery, as a matter of fact. So in the presence of a subpulmonary VSD, which is present here, this can also be called a Towsing-Bing anomaly, which is a variation of transposition where you have a subpulmonary ventricular septal defect. So some cases, as you can see, can fit more than one variation of the spectrum. So let's take a look at this next example of double outlet right ventricle and the Rastali operation. Here I want to open the right ventricle and show you the internal anatomy. This was a baffle that was surgeon's place that I removed to show you that this is the aorta rising from the right ventricle, and this is the pulmonary artery, actually. Let me hold this patch well here. So that's the pulmonary artery where it should be. In this case, the valve is atretic. So we have pulmonary atresia. And this is the VSD. It's a subpulmonary VSD. So, and one way of doing this operation is to close the defect into that valve, into the pulmonary valve, and with a patch like this, and then switch the great arteries if the pulmonary valve is patent. However, because the valve is atretic, the surgeon decided to place the baffle from the VSD in this way to include the VSD flow into the aorta that way, and remove this outlet septum and relieve the aortic outflow obstruction that was present. So this way. So the baffle, and then create this conduit from the right ventricle out to have a right ventricular outflow tract to the pulmonary artery to place this conduit from the RV to the pulmonary artery in that fashion. So to summarize, there are 4 types of double outlet right ventricle. The first is the tetralogy of Fallot type, when there is a subarterial ventricular septal defect and pulmonary stenosis present or maybe absent. The second type is a Towsing-Bing anomaly, which we showed a variation of, which is a variant also of transposition of the great arteries. The third type is a doubly committed ventricular septal defect, and the fourth type is a remote ventricular septal defect with double outlet right ventricle. Now, thank you again for your attention, and we will see you in the next video.